Hi everyone. I'm Lena Sanchi. I'm Head of Department of General Practice at University of Melbourne, and I'm a GP by background. I did my PhD for Centre for Adolescent Health at the Royal Children's Hospital and worked there for some 10 years in adolescent health and medicine, and my PhD was on designing training and education for general practitioners to work well with young people. And I went into that topic because I didn't know how to work well with young people. So I spent 4 years answering my own question and then the rest of my professional life for about 20 years kind of trying to also help the system of general practice cope well with young people. So I come to you with that background, and I'm also, because of that background, the medical advisor for the Doctors in Secondary Schools program. And our university, thanks Tim, our university has been awarded the training contract to provide the clinical training and support for the doctors and nurses and school staff in that particular program. So I'll also be here while you're learning about that if any of you are interested. I just wonder, I understand we've got a mix of people in the room. How many are GPs in the room? Great. And how many nurses? Yep. And practice managers? Okay. And have we got anyone else? Any other teacher? I know, Tanya, isn't it? You're from the school, and we'll talk to you a bit later. But any other disciplines?
I'm still training in the hospital.
Training in the hospital, like a hospital registrar. Okay, great. All right. And has anyone heard about doctors in secondary schools before, just out of interest? Few. So there's a little bit of interest in hearing about that later. Okay. So the first part of this talk is really more about youth-friendly general practice as a generic thing, no matter what discipline or place of work. And I've only got an hour to talk about a big topic, but I was asked to particularly focus on medico-legal issues, but I'll embed that in a case where we'll address the whole thing. And if anyone has heard me speak in the past, or some of my colleagues, a lot of the science around this really hasn't changed a lot over the last few decades. And many of you who've probably got experience with young people or have learned over time will have developed a lot of the strategies that I'm going to talk about. So maybe what I'm going to say will validate what you already do, and you might pick up a few tips here and there. So hopefully that's the case. But what I really want to impress on you that all the latest surveys of young people and the National Youth Mental Health Survey that was done most recently still show that general practice is the most commonly accessed health service by young people, far and wide. And second to that is some sort of service at school, and this is for mental health issues. So we are very important in that journey. And only around 10% of young people with mental health problems go to Headspace. So even though we've got Headspace, which is a wonderful resource, it is still general practice that has to provide the bulk of care. So it's really, really important that we do it well. So I really am very passionate about this and very passionate about getting this work going well in general practice. So you'll learn about the elephants in a minute when we talk about the next bit. I don't know if this is going to work. Oh, yeah, I'll do it from here. Oh, there we go. Okay, so we're going to follow a case, and I've picked this guy Declan, who's in this splendid family, and he's a 16-year-old young man who would present to general practice. So he presents to your clinic and asks the reception team for an appointment. Although his family's known to you, this is the first time he's attended alone, and he appears to be really quite nervous. Now, has anyone met this sort of young man coming to reception? Yeah. So what I want to show you this video, and I want to prepare you that it's a bit of a joke video, right? So it's a bit not like true life, but in several jokes of bad practice, we might see a grain of something that might resemble a barrier in our own practice. And this video was created by young people to demonstrate some of the things that are a bit larger than life. I also put another caveat that it's from the 1990s, so you're going to see some really funny dressing and all that sort of thing, but it's called bad practice in that we're hamming it up. But when you're watching it, I just want you to take note of some of the barriers you think these kids might be facing, and we'll just use that as a springboard for youth-friendly practice. So, and it's got a good practice version too. If we get time, we can watch it. So yeah, you can launch this. and hopefully it will work. It was working. I couldn't shut it up before.
Jake have been friends since we were about 12, and you know, he's usually up for everything, but lately he's just not himself. Like, he's too tired to come out with me, and he's doing really bad at school. And every time I go to his place, he's just like vegging out. I thought something might be wrong, so I made him come see a doctor.
No, don't tell me. My card. I've forgotten my gold card.
That's fine, Mrs. Thompson. It's not a problem. I've got all your details on file.
Oh, thank you, dear.
Can I help you?
I'd like to see a doctor.
Do you have an appointment?
No.
Well, look, the doctor's completely booked out today. I can get you in Thursday, 1:15.
It's kind of urgent.
I'll try and fit you in, you'll have to wait. Name? Name. What's your name?
His name's Jake.
Jake Allen.
Jake. You're Bev's boy. Why didn't you say so? How's your mum? Haven't seen for ages. She good? And what about you? I wouldn't have recognised you. You're growing into such a handsome young man. Who's this? Is it your girlfriend? She looks nice.
Oh, we're just friends.
Well, can I have your Medicare card, Jake?
Medicare card.
Look, without a Medicare card, Jake, it's going to cost you $45. Or I can call your mum, we can put it on her card.
No, I can pay.
Look, next time, Jake, get your mum to call ahead and make an appointment, okay? Better yet, get her to bring you in and I'll have a chat with her. Tell her Marge says hi.
What can I do for you? I just feel a bit weird. Weird?
Now, I want you to come back in a week so that we can check the results and see how you're going.
Next week? I was hoping you'd give me something now.
I can't prescribe something if I don't know what the problem is. We did fit you in at the last minute after all. Now, I want you to come back next week. How does Thursday sound? If it gets worse in the meantime, you'll have to go up to the A&E. See the receptionist. She'll make an appointment for you. Young people are so difficult to communicate with. I mean, I'm not a mind reader. I do my best to try and fit them in, but I've got a waiting room full of people. I'm a GP, but I'm also trying to run a business. I worry about how complex their problems are. But, I mean, realistically, how much can I achieve in 10 minutes?
Well, everyone says when you're sick you should go see a doctor. I don't really know how blood test is going to help. I know there's something wrong with me, I just don't know what. I don't really think he cares. Don't think I do either.
Ooh, okay. So, as I said, it's a sort of jesty one, but in watching that, we saw a whole of practice that wasn't working too well for young people. And in youth-friendly care, we need a whole of practice approach. What did you sort of notice there would be easy fixes for you, or things to take notice of in the preparation of staff and in your approach to young people? What do you think were the barriers that this kid might have faced, right from the time he walked in the door from reception through to the waiting room, seeing the doctor, and then even coming out again, knowing what to do next? Anyone want to offer an observation of something that's not right that you would do different? And just as a thing, in general, young people do value their general practice service. We don't get really bad evaluations, but it's not really good either, I have to say. I think it's around 6 or 7 out of 10 in some of the national surveys as their rating of primary care. Okay, Privacy, yep. Can you elaborate? Patronising from the doctor and receptionist, yep.
Non-judgmental.
Yes, yeah. If you could be a bit non-judgmental, there lots of judgments made. There was the person who was with the girlfriend. The privacy was breached right from the beginning, and that happens in a rural town. So quite often kids don't even want to come in if they know who's booked into the waiting room, or even other places. Yep.
There's a bit of a rude as well.
Pardon?
The rudeness.
Rudeness. Yeah, there was a bit of rudeness, a sharp edge to it. Yes. Cost, not knowing how the system works, don't know the Medicare card. We could probably add my health record confusion to that now also. Yep.
We're very smiling.
Yeah, no, not much friendliness. No. How common is it, do you think, where young people look down when they come, if they come on their own?
Shyness.
Shyness. Yeah, and what is that about? What's that shyness about?
About speaking up about what's going on.
Yeah, exactly. So at their developmental stage, when they're starting to learn how to be adults and put themselves out there, it's quite difficult to do, especially if there's something wrong. So often this introverted appearance is misinterpreted as being a bit standoffish by staff, or people just thinking, oh, they're difficult, or oh, I'm not going to be able to communicate with them. But a little bit of understanding might soften that a little bit. Yeah, that's good. Anything else in the environment or
Resources in the waiting room.
Yeah, sure. And how about the GP?
Rushing, no eye contact.
No eye contact.
Rushing.
Yeah.
The miscommunication.
The miscommunication. And and the confidentiality bits. Yeah, so look, all these things, is it true how much can you achieve in 10 minutes? What do you reckon about that?
If it's true that you can't actually achieve within that 10 minutes, but still you can actually listen and have an eye
What
contact.
can you achieve in 10 minutes? What can you?
Rapport.
Rapport. And a feeling. So there's the rapport with the individual doctor, but there has to be also rapport with the practice. So at a system level, from the minute a kid walks in the door, what could the receptionist do to make that young person feel welcome and connected and safe? So that's the sort of stuff we'll be talking about. Okay, so going back to the case, Tamara, I don't know if I need your help here. Get it back. Okay, here we go. Yeah, so you picked up on the should be, oh, now I've lost it again. Oh no, there we go. Yeah. So you basically picked up on the 5. It's not arrow. Oh, it's that arrow. Yeah. Okay. So the 5 C's. There's been 20 years of research on the barriers young people face to accessing care. So this is what it has boiled down to consistently, no matter what country you're in or culture or time. Worried about confidentiality, worried about cost is probably the most important barrier now. Worried about being able to communicate well with that old person who might have known me since a kid, and what are they going to think about me? So that's the issues of compassion. Compassion meaning, are they going to be judgmental or not? And also how do you get there? How convenient is it to get there when someone always expects me to be somewhere? I either have to be at school, or I have to be home by a certain time, or I'm going to sport. Not that easy to front up for care, which is one of the reasons that school-based care is of interest to us. And then your developmental stage, which is what you're saying, a bit shy, inexperienced, maybe not really knowing what's going on for me, so therefore that's a bit of a barrier. So those things are what do it. And again, back to that developmental stage, if you think about what's going on for kids, the areas of physical development, intellectual, emotional, all going on together and often at different rates relative to one another, and depending on their level of experience and exposure. Can you see? So that all those things are happening, and this is the potted version of the developmental stage, and we can divide youth into 3 phases. So the young ones who are under 14, their key question, they're starting to grow and develop physically, and their key question is, am I normal? And they're very self-conscious. Does anyone have 13-year-olds at home or can remember what that's like? And that's a difficult age to communicate with because they might be fairly concrete, and you need to offer more to bring them out and make them feel more empowered. Middle adolescents are really exploring their place in the world and thinking more abstractly and starting to daydream and really be very heavily into peer group, and that's your who am I kind of phase. Who am I? Where do I fit in? What do I stand for? And the late adolescence is, you know, where am I going in life? They're starting to engage with the broader questions. So when you're seeing an adolescent in the clinic, you might see a difference in communication based on those. So the good medical care of a young person doesn't depend on what specialty or discipline you come on, but your sensitivity to all of those things going on. And I can see that you're all aware of it. And there have been guidebooks on youth-friendly services. So I'm happy to leave these slides because they probably will flash by quickly. So if you don't catch it, don't worry, I can leave it with. So they need to be available and accessible with flexible appointment times. And another reason why school clinics often work well, equitable. So in our country, we tend to have equitable access, but in some places in the world, if you are gay or you are of a different culture, you may not feel welcome in certain practices. Acceptable, so things that are in the waiting room that are acceptable to young people. Having a clinic that prides itself in privacy and care for the young person and being respectful of that and wanting to empower them, giving feedback and negotiating plans with them, working with them. So this is good for any patient, but your adolescents are your canaries in the coal mine. If you can engage them, you will probably engage almost any patient that walks in the door. Developmentally appropriate, so understanding what's going on for use, being non-judgmental, and that doesn't mean condoning risky behaviour, but being accepting that things happen and how can we work to minimise harm. And then being effective. So there are evidence-based guidelines with respect to treatment of infections, for vaccinations, for depression treatment and those things. So that's how, these are the sorts of things that in quality care indicators you might be able to pull out of files or whatever if they're quality improvement activities. So our key clinical skills we'll go through in a moment, but understanding developmental perspective we've just covered. Then it's about getting time to talk with young people on their own and these things, which we'll come back to that. And we've talked about having a whole of practice approach. And part of making your practice feel comfortable with this is to know who's in the network that you can refer to. They might be the youth workers, social work, allied health, family planning organisations, and Headspace or something like that. So dealing well with adolescents, the right attitude, the right approach, and dealing with accessibility issues. All right, so now back to Declan. So he intends to be going in alone, and he enters the room and sits down because he's fitted in. He says, I'm worried, I've caught something down there. Okay, so how would you now like to proceed with Declan? What would you do? He's come in, he's sat down, so the clinicians in the room, the nurses and the doctors might like to answer this question. So receptionist, you're off the hook at the moment. You've passed it on now. You've been so nice to this young man. He feels comfortable to come and sit with the doctor or the nurse actually, and maybe what's your next step?
Ask what makes them think that there's something.
Problem. Yep. Okay. Any other high level things you want to be able to do?
First, we will ask why this patient can be acquired here.
Yeah. Why has he come?
Yeah, well, and also about mental health.
Yeah.
That's how we can address the issue.
Yeah. So make him comfortable. He's come to the right place, and you can. And what do you think might be going on just from that opening statement? Pardon?
As a doctor, I would literally, I was like thinking my studies.
Yes, yeah. Introduce yourself, make him comfortable. Certainly. Okay, good. So we want to know his presenting complaint and his underlying concerns, which you've all said. No one said confidentiality statement. We want to talk about confidentiality pretty early on, and we'll go through why in a moment, and take a sexual history, because I think something he said, I'm worried I've caught something down there, maybe gives us an impression. Now, we can't jump to confusions, but it seems like there might be something going on there. All right. So this is a framework, and those sort of things that you mentioned go in. So of course, welcoming introductions, they break down the barriers straight away and make someone feel comfortable. So, you know, hi, I'm so-and-so, I'm the doctor here, or I'm the nurse here, and I'm going to sit down and talk to you today, and I might ask you a lot of questions to check how your health's going, as well as deal with what you've come in for. Just explaining who you are, what you do, why you're doing it. Validate the concerns. So yeah, okay, so it sounds like you're quite worried about this. Let's, you know, take it on board, take it seriously. Okay, so it's really great you've come in, you've come to the right place, I can help you with this. And that all goes towards this. And these sort of principles I'm outlining are also part of trauma-informed care, and we'll hear more of these sorts of terms. It's taking care of people and bringing them on the journey, but you really need to do this with use. Okay, so there's other steps here which we'll come to. Negotiating time alone if you come in with a parent, and confidentiality statement, and then explaining the purpose, asking permission when going into sensitive areas, and giving permission not to answer. All right, so what if he does present with his mother? Again, his family is known to you. The mother says, I want you to check Dylan out. He's been really anxious lately and he thinks there's something wrong, but he won't tell me what it is. I'm worried about him, doctor. He's missed school today and yesterday. What are you going to do now? What's your response as the clinician sitting across from Declan and his mum, and they've come in with that question?
The question will be first, if the mom has not anything planned, or she, or if she can recall whether this is the first time it's happening, and if there is any family issues.
Sure. So you might
issues.
take the opportunity to get a combined history of what might be going on. So I think that's right. What are the key things that you might want to do in a young person who's a bit reticent, and you think nothing much, the mother doesn't know much, you've gone through, there's no really significant family history, it's been going on a week or so, and he's otherwise quite well that she knows of. Where do you go from there?
History taking alone with the
Yeah, so you might want to get a history alone. Why do you think that's important?
sometimes you won't be able to talk in front of the mother.
Yeah. Yeah, privacy. So we do still see some kids come and get asked a lot of personal questions in front of parents, and I think that's risky until you really understand what's going on, because you may not get the truth. So I agree. So history of presenting complaint, you still get the underlying concerns. Validate the mother's concerns, because in a minute you're going to negotiate for some time alone with Declan, and that won't be good if she doesn't feel heard. And you really want to involve her as a supportive carer. It's great that she's brought him along. So thanks, Tanya. I hear what you're saying, and it sounds like Declan, you're not quite sure what's going on. We've cleared up some of the history, but now I think it's time's come. I need to have a chat with Declan on his own. This is the usual way I do things here. I want to get some time with Declan by himself and have a chat to him, and then we'll wrap up together with what might happen. And we might also talk about confidentiality with the parent in the room. Has anyone done that? Does people do that? Yeah? Okay, you're comfortable. What sort of things do you say? And Sandra, you're here, hello. You don't need to hear this bit, but what?
Just with the mother.
Mm.
Yeah. So talk about the confidentiality, whether it's can't be actually reached even to the parent.
Yeah.
If he's not willing to.
If he's not willing to.
And it's not harmful.
Yeah, as long as there's no harm. So generally I would say something like that this is my usual practice with young people is to spend a bit of time. Sometimes they feel comfortable talking about things that they may not feel comfortable initially when we're all together. And it's also to let you know that what we talk about is between us. And I would keep what he wants to say private, except with his permission. And if there are some sort of issues going on that are a concern for his life and his well-being, they're the times at which I would need to involve other people. If his life is in some sort of danger or something serious, you can be rest assured we would tell you that. but otherwise we will tell you the things that are necessary to work together on this problem. Something like that. What do you do?
Yeah, I agree. I think because parents are often really anxious that once they're out of the room, there's going to be something disclosed that they're not going to know about, and they're really worried. So
they want to know you're going to bring them on board. And I must say, the teachers, when we talk about this, they're worried. Like when we come to talking about the schools, the teachers are worried.
I'm actually a teacher. I'm a psychologist.
It's like, oh well, this is your field.
Yes.
Well,
they're totally very
when we started Doctors in Schools, and the fact is that young people are consulting without family there, the teachers are like the parents. They're very worried that will we hear about what's going on, because we need to take care of them, and we have to respect that concern, but also lay down the communication rules. And so everything is private unless we've got permission from the patient, and when there's serious issues we have to share. So in summary, see the young person or explain confidentiality or process who you are, and then we go to this HEDS assessment. So there has been a randomised trial on discussing confidentiality and discussing it early with the exceptions, and they noted that the young people who were exposed to a confidentiality statement prior to a consultation were more comfortable, less anxious, more trusting and more willing to return. So it's worth getting your patter going on that. And they're also more willing to disclose information. So whether it's actually what they're hearing or the fact that you've taken the time to explain it, it's unsure what's the most important thing. But if a doctor or nurse is taking the time to explain this to them, then they feel like you care. And there is exceptions to confidentiality, and that has to also be explained early on. So if you were telling me something, Declan, what we talk about is between us. I won't tell anyone else without your permission. I might try and talk with you about what might be sensible to tell other people if it's going to help you. But there are some areas where I can't keep it just between us, and that is if your life is in some sort of danger. So if you were going to tell me you felt like really seriously harming yourself, harming someone else, or if someone was abusing you, they're examples of the times we need to talk to other people to keep you safe, and I'll try and do that together. Sometimes you'll get kids part of court orders where that might be necessary to explain. So when we've practiced this in a group, it's taken the slowest person about 90 seconds. So even in a 10-minute interview, it's worth getting that across. And they're the sort of areas where you might have to break the things that I said, but also some of the things like notifiable diseases, etc. But they're a slightly different thing where it's a form. So I won't go through that, but it's basically what I was said. It is important to explore with the young person who does want to be on their own and not tell parents things, a little bit about the family dynamic and the degree of support there, and understand that so you can work with that later. And if you do need to talk, sometimes you do need to talk to parents or to teachers about how that young person's functioning in other parts of their life, but then you ask their permission to do that. So talk with the young person about, I'd really like to ask your teachers how you're functioning in this environment at school. What I'm thinking of saying is just exploring that, just to see how you're going. I'm not going to tell them any of the details that you've told me. What do you think of that? Or is there anything you would like me to share? So it's always getting that permission before sharing the information. Okay, what about friends? Would we separate friends out? What do you guys do?
They may feel more comfortable with friends, so I wouldn't unless they want to.
Yes.
We ask them.
You ask them? And ask them, yes. Yeah, with friends, I must say I've got a lower bar, and I do ask them, and they usually say they know more about me than anyone else, and it tends to be okay. But I do warn the young person, I might be asking some personal stuff. Are you happy for your friend to be here at that time? Yes or no? What about partners? An intimate partner? Yeah, you could ask. And sometimes you gauge it. I'm more likely to separate partners in case there's any abuse or going on, or power relationships.
Because probably at this time, the adolescent are closer to their friend than to their parent or their others.
That's true. But a boyfriend or girlfriend or other partner, whatever gender, there's sometimes control issues that we need to be able to explore with the person on their own. So yes, I agree. Friend, maybe a different dynamic, but asking is always good. But with a partner, I would be a bit like with the parent. I would suggest that it happens. Okay, so this, so we've got a bit of history, and okay, does anyone, if we're exploring sexual history, what are your golden rules there? It's usually how you ask the questions. Would you like to offer it? I think you look like you might know a bit about this. How would you start a sexual history with a young person? Any sorts of goals that you would have there?
I suppose, yeah, I'd try and build a rapport first.
Yes.
Something that they're not going to be initially comfortable talking about. But I suppose just finding out first what he's worried about and what the symptoms are, and yeah, just making him feel at ease really, so that
yes,
you know, he can tell you anything that he's worried about. So I suppose just taking a good history and
so some of the recipes about a good history in sexual history, because this is often the one that stumps everybody a little bit in practice, is just to be very matter of fact and very don't assume anything. So be very gender neutral. And there's just some key steps you've got to go through. You know, are you sexually active at the moment? What type of sex are you having? You know, are you having sex with guys or girls or both? You might even want to know how they like to define themselves. Do they define themselves in a gender? What are their preferred pronouns? And if they're, you know, and are they using? And then you're down to plumbing. Are they using any protection? If they had unprotected sex, when was the last time? And what were the risk factors of the partner that they had sex with, to get a bit of a sense of what sort of tests you need to do. So the gender neutral and not assuming their own gender either, they're all the kinds of things that you have to have in your mind. So he had last sex was a week ago with a casual male partner, and also don't assume relationships because they might be hooking up and just be. He didn't use any condoms, mutual oral sex, receptive anal sex, 2 other partners in the last 6 months, a casual female partner, a regular male partner with oral sex, no condom and receptive anal sex. He identifies himself as gay, recently came out to family and friends, and some weekend alcohol use, no drug use. All right, so lots going on there potentially. We've got a lot we have to deal with. What other things in life? So are we going to stop there or not? Who wants to stop there and just deal with that stuff? Obviously not.
You want to do the head screen.
You do want to do the head screen, so you guys know. So in the head screen, it's worth remembering youth. This is where the peak of all these influences happen in adolescence and adulthood, the media, the peers, employment, education, and your family of origin is sort of influential, but then it declines as you get older. So these are the things that are often going on for young people: mental health issues, risk-taking behaviour, and a small amount of the pie surviving into adulthood. And yet they're not the things that tend to worry young people. They worry young people. They're not the things that tend to present to general practice. So concerns about these things, which are often hidden, and often they have fears. This study that was done in Victorian general practice, out of 400 youth, about 43% have a fear of something. This guy's had a fear that's influenced his presentation. So again, in the approach, it's worth knowing. And yet, most of the consultations are for physical things, and only a small amount for psychosocial things. So unless you ask with your screening questions, you won't know. So you're trying to work out in each of the worlds of a young person, so living within their inner world, the school, the peer, the family world, what is the balance of risk and protective factors in their life? And that a question around that is, how connected are they to their worlds? How safe, how valued, how listened to are they in each of these worlds? What's going well, what isn't going well? So you can get a sense of levels of risk. And the sophisticated Bronfenbrenner model also takes into account the bigger picture. So in a young man like Declan, the gay marriage debate might have had an impact on his mental health or his ability to come out and deal with these sorts of issues. So having an eye to the macro is also important in the micro. So risk factors increase their likelihood of behavioural or emotional disorder, and protective factors improve that. So again, feeling safe, valued and listened to creates connectedness, which promotes well-being. And helping families understand this is really important. Creating this environment in your general practice is really important. And part of the way of creating a sense of connectedness is giving young people opportunity to learn skills that are meaningful to them and to use them and get good feedback on them. So we can model that in our consultation as well with young people. And the resilience factors, there's a lot of focus on risk, but we have to focus on positive youth development too, and being able to bring out what are the good things in young people's lives. So what are their strengths when we're talking to them, and their talents that we want to enhance, and help them identify, even if it's being able to turn up to an appointment, express their thoughts. Gosh, you know, that's difficult for you to talk to me about a sensitive topic, and you've done great to do that today. That's very important. Educate parents about the strengths of that too. You know, if you're together with the parent, being able to model that so-and-so's, when they come back in the room, oh, Declan's been really cooperative and he's got some good insights into his health and well-being. That's great. He's willing to look after himself. You might model something like that for parents. Provide guidance around normal adolescent development. So discuss ways, you know, reassure young people when they're going okay, or that these sorts of things that might be worrying them are actually normal for someone going through their experience, or given if they've had a past history of trauma, given what they're going through, these experiences are normal, and actually they've shown some strength in coping. So being able to reward that and cultivate good networks, and then collaborate with their other carers to work that out. So it brings us to the HEADS approach. Has anyone not heard of HEADS? Any of the clinicians? Your reception? Nurse?
I'm just starting out.
Just starting out? So, okay, so we need to, this is a fundamental, it's a lovely framework that we've all been taught in how to navigate around those four worlds. And it's just a little mind map of what to talk about with a young person to evaluate how they're going in different areas of their life. You don't have to do it in any order, but you need to do it when there's rapport. You've discussed confidentiality, and it's just to remind you the areas. So home, where do you live? Who lives with you? Who do you get along with? What's going well? What isn't at home? Is there anyone you can go to with problems? E, so lots of E's: education, employment, eating, exercise. How are you going at school? Often kids find it much easier to start with their education or their employment than with home. Home's often a personal, sensitive place. Activities and peers. What sort of things do you do when you're not at work, at school, or at school? What interests do you have? What do you think you're good at? What might be a bit challenging for you? Really trying to understand. And if kids are not turning up much positives to anything, you know you're in a higher risk situation. Then you get on to the drugs, cigarettes, alcohol, screening about those sorts of things. I'm not really got time to go into the detail of how you do this effectively, but there's a lot of good reading and training. But this is the areas you cover: the sex, sexuality screen, psychiatric symptoms, and especially screening for suicide risk if there's any depression. And then there's things for safety and spirituality. And other things in safety might be, are they immunised, and are they, doing safe sex, and have they got road safety practices as well, given that accidents are the highest killer. It's important to get time to go through the HEADS during your relationship with a young person. May not be all on one consultation, because having one risk is usually associated with other risks. So in our longitudinal work, being a regular smoker seems to be associated with a lot of other psychosocial risks, like mental health risks. And can you actually think? Sorry, I might be standing in the way. I might have to go swap around. Okay, so we get a bit more of an accurate diagnosis and really understand where our intervention might be. So we really, when you're talking to Declan more widely, you want to know, is he at the age appropriate stage for adolescence, or where is he is he able to understand and engage and express himself, or is he more mature in some ways and not in others? How has he gone with his developmental tasks, so his sense of independence, his ability to engage at school and with peers? What other things are going on? We've heard a bit about him coming out. How well is that going in his life? How well is he being able to integrate that? And then after our assessment, we should be able to see whether he's troubled, vulnerable, well-adjusted or out of control. So and most young people are going fine, but about 1 in 5 will have a significant issue. All right, so I might just skip through this. So this is when we worry about risk. Obviously, if it has any of these things, interferes with their ability to grow and develop, when it masks depression and so on. Okay, so we've heard a bit about home, a little bit. This is Declan, but I might just go to his head. So home, he lives with his mum and his stepfather and sister and brother. His mother and Rob are not happy that he's gay, and he hasn't seen his father since he left the marriage when Declan was 2. He's in year 10, he's maintaining his grades, no part-time work yet, eating normally, hasn't been going out since he broke up with the boyfriend. He plays online games, has some close and supportive friends, and is part of a standout group. So it's an advocacy group for gay young people. Denies smoking and alcohol and drug use, but drinks alcohol at parties. Has had 3 sexual partners in the last year, 1 female, 2 male. Identifies as gay, recently came out, oral and receptive anal sex, unprotected sex with the last partner, no abuse, and he experiences anxiety, but not really, a bit of low mood a few years ago, but not really any depression, maybe a little bit of anxiousness, which is related to his family situation. And he feels safe at home, but anxious in public places, unfamiliar to him. So given that history, do you have any concerns? What are the risk factors you're worried about with Declan, or that you want to highlight as you're going through?
I think overall he's actually doing pretty well.
So overall, so you're like to profit. Overall, he's doing quite well.
I think he's doing pretty well, and commend him on that. He just sounds like he just needs some education to upskill on some safe practices.
Okay.
He seems to have quite a good support network. And
Yep, so a lot of strength there.
Yeah.
Yeah.
I was just concerned about the sexually transmitted disease.
Yes.
You already said that
Yes.
we have to explore it.
We have to explore that more. Yep.
I think his kind of social support, I mean, he doesn't really have probably family members he can really talk to. So then his friends might largely centre around the gaming, which may not actually be real relationships. So it's social connectedness I would worry about.
Yes, yeah, sure. Okay, so what are the supports in the gaming might be an issue?
Yes, the anxiety.
Yes,
signs,
anxiety.
Start of something maybe or pretty cool.
Yeah.
And,
another question, if there is any suicidal ideation?
He has none. No, he said he has none. No suicidal, a bit of anxiety. Okay, so overall he's travelling okay. There are some behaviours that are a risk, and so he's one to monitor and assess over time. Okay, so your any medico-legal concerns? What are the medico-legal issues that come to mind with this 16-year-old gay young man, or bisexual kind, and who has had unprotected sex? Any medico-legal issues?
The age of the other partner.
Age of the other partner. Yep. So that's
just trying to establish if there's anything untoward coercion or pressure.
Yes, any pressure or abuse. Yep. Any
family violence or
yes, any violence? We're going to have to treat him with something.
Anxiety.
Yes. So yeah. Okay. And investigations management plan. What what are you going to do to this young man? Oh, it's not about a sexual transmitted infection talk, but just while we're here, and I won't dwell too much on that, but
Just the
Also
main
the
thing is
the symptoms, is it just,
he's asymptomatic.
so you're just worried about, so then you can just organise the initial STI screening.
So
Did we show
his partner, he's had a
He's had a text from
So
the
he's
partner
fine.
who's got chlamydia. Yeah, the partner's got chlamydia. Yeah, sorry, I flashed that through that quick. I was hoping I'd put that up. Did you have something you wanted to
I was
say?
going to say, I guess the main thing is to address what he came in for.
Yes.
Initially, it's probably the first step,
Yes.
which is a STI concern.
Yes, that's
and then
right.
probably raise other concerns that has come up, maybe in a
Yes.
summary, and
Perfect.
then obviously trying to organise a follow-up soon,
Yeah.
where we can then explore those in further steps.
Beautiful. Okay. Okay, great. So you're all pretty hot on this. So yes, so you've got all of this. You've listed all those concerns, and you've also picked up the protective factors here. So good. So the medico-legal concerns, the consent to treatment, confidentiality, legal consent, and privacy. So this is where I'm going to recap on that. Are we going all right? So far, so good. Okay, so this is where we're going into the medico-legal stuff. Age of consent in Victoria. So obviously no sex when you're a child, and this doesn't matter what genders are involved. So sex is allowed if the age of consent for sexual intercourse is 16. If you're under 16, the law says that sex is not illegal if there is if the partner is only 1 or 2 years older than you. Unless the older person thought you were more, but by and large, that's the only defence. However, if there's more than 2 years gap, then it's an illegal act to have sex with someone who's under 16. There's this grey area that if they're between 16 and 17 and the partner's in a position of power over that person, that's also illegal. So that's important, those age of consent. So you do want to know the gender of the partner. Now, mandatory reporting. So are people happy in large with the mandatory? It is a very difficult area when you get to 17. There's a bit of a shade of grey, but generally a child, if you believe on any reasonable grounds that a child is suffering harm or likely to suffer harm, then you need to make a mandatory report about that. Particularly if the parents of the child are not able to protect that child. Quite sometimes if there are protective factors at the home, then child protection won't investigate that unless there are other people at risk. They are so busy that they really get involved with the quite life-threatening ones. If there is protection at home, they may not do it, but still you probably would want to make a report that assess that level of risk. Now, has anyone heard of the failure to disclose offence, which complicates things? So it came about as a result of the Royal Commission, and it's a very important outcome in some ways because it's trying to nab the sexual offenders so that they never really get away with it. But it does introduce some issues for us in the way the law strictly interprets abuse. So it's a new law. So basically any adult in the community, so all of us as community members, if we believe that a sexual offence has happened, we're all mandated to report that offence to the police, even if the offence has happened in the past. But there are several exemptions to this. So if the information is given to a doctor or a counsellor in the course of a confidential conversation as confidential information, then you don't have to report that unless you are worried the person has actually been abused. So if there is someone that has not dealt with them well and there's been force or abuse, we always have to report it. But we're talking about a situation where you might have had more than 2 years gap in the sex age. So a typical scenario might be a year 10 and a year 12 partners in high school. They're in the same school, one's 15, one's 18. There's more than 2 years gap. It's quite conceivable that happens, and we know it does, and that happens in our practice all the time. If you know about that in the general public, technically you'd have to report that. If we come to hear about that age difference from the 15-year-old in consultation, we don't have to report it. It's consensual. There's no abuse. There's no relative involved. It's not someone in a position of power. We're comfortable. It's kind of a normal adolescent relationship. We don't have to report it if it's told to us confidentially. And if we're a medical practitioner, and
Yeah, I'm sorry to interrupt, but this is the point that it's not that clear for me. There is a 15 and 18, and you are worried there is this violence or so should I tell the 15 years old that I have to report it to authority, or
you don't have to, if you're worried there's violence, yes. If you're worried that 15-year-old is actually being abused, then you would need to report that to the authorities, because this is one of the exceptions to confidentiality. So you told them at the beginning, the times that I can't keep this secret between us is if you're being abused in any way. Now, what you've told me here is really serious. Your life and your well-being is at risk because someone is abusing you sexually. So this is one of the times I'm going to have to break confidentiality to keep you safe. And this means, and in that case, I would probably call child protection above the police, and child protection will sort out whoever else needs to be called. Myself, I prefer to call them, but you could also call the police and they would refer it. If you're not sure, there are new organisations now called Child First, which are in several communities, and they can give you advice on who to call. And Child First are good to refer to if you're not sure, if it's more vulnerability than abuse, than straight out abuse. If the young person is with other people, it's consensual and a little bit, she's not really being abused, but she might be a bit vulnerable. The family's not stopping it. They're aware and they're kind of unsure how to help their young person. I'd call that a vulnerable family, and I would call Child First because they can intervene with vulnerability before it gets reported to Child Protection. And that they're quite new. Has anyone heard of them? Yeah. Yeah.
The parents need to agree to that.
Yes. Okay. And I guess when you're wanting to refer to Child First, you're quite concerned about that family that you'd have that conversation with the young person. Yeah. So the parents
need to know that they need to accept the referral.
They accept the referral. So it's not a perfect system still. Yeah. This area is not actually, I think there's a lot of work to do in child vulnerability and protection. We don't really have good systems. Would you agree? Yeah. I think the whole issue of trauma and our support for unveiling these sort of things is quite fraught still.
And if the child refused or say please don't, or the parents they refused,
no, you have to do it. Yes.
And this will means that this patient will not come back again, and I will.
Well, yes. Do you want to? Yeah, maybe
Yeah,
not. We have a conversation around this, and it's exactly that sort of thing. And I have a bit of that in the slides that you can take later. But I know you're not going to want me to do this, and this isn't popular with you, and you probably won't like me for this. But it's important that I do this to keep you safe. And is there anyone else you want me to tell so that you can have some support? That I need to make this report. I mean, sometimes they used to say we can report without telling you, but I think in general it's better to share that. Yeah. Yes.
I don't know if it's a stupid question, but I don't know if it's clear, but it says even if it's happened in the past. So how far?
If it happened when the person was a child, then we have to report it. And unless the person is 16 and is mature enough to say don't report it. So now I don't want to confuse you when we're talking about offence and abuse here. So when there's abuse, we always have to report it, whether the person's 16 or not. That has to be. Well, sorry, rephrase that. If the person is 16 and they come in and say, this abuse happened when I was 13, but it's no longer an issue, that person's out of my life, I don't want to report it, and they're currently safe and everything, we don't have to report it. If you think that young person's a mature minor, so they understand fully the repercussions of this decision and all of that sort of thing, then you don't have to report it. But if the young person comes in and they're 13 and they say to you, this abuse happened to me when I was 6 and it was an uncle who moved away and no longer lives here, you do have to report that, because that person is not held in this new law to be of an age mature enough to understand the repercussions of that decision. Now, we can argue that, but that's what the law says. So, and that's because it's happened in the past, not now. Whereas mandatory reporting focuses on at risk now, failure to disclose also incorporates past risk for sexual abuse. Yeah.
So I was following up on that, and you're probably going to talk about mature minor. So that principle, is that actually typically a cut-off for that, or is it only based on your judgment?
It's based on your judgment, but anything under 14 is very hard to argue for total maturity, because the psychological research studies tend to show decision-making capacity is probably there from 14 and above, and under it really is very variable. So you need to get a second opinion about maturity. They might be mature for some things and not for other things, and some of these longer-term risk factors. I'm talking this way about this particular issue because we actually had a case of this amongst we educators. So Bianca Forrester, who normally trains with me, and she had actually had reassured the 13-year-old, we wouldn't have to say, because the 13-year-old actually was functioning like a mature minor, and said, I'll tell you, but I don't want to report it to anyone because it's not an issue now. And I want help, but it's not an issue now. So she promised that. But when she rang to get help, the services wouldn't take her unless it was reported to police because she was 13. So this is the way the law is playing out. So I think, again, if there's confusion, that you call and just ask for advice. You could call the police and ask for advice, and that's what she did, and they said no, report it. Or you could call Child Protection or Child First and get some guidance on that. But if it's clearly not abuse that's happened, if it's a relationship that the person has had, and they're 16 and they don't want to report it, or even if they're under 16, there was no abuse, I wouldn't report that.
Can I ask a question about the 3-year gap?
Yeah.
I heard somewhere with the 3-year gap that if they were together, and they were 10 and 13, and then they're 15 and 18, then that 3-year gap is okay because they've been together.
Sex is always an offence if it's with someone under 12. Just always.
So, well, okay, let's change that. Because
if it's a
13 and 18, so if they were together from, say, 13 and 16, so they've been together for 3 years, and then there's that gap because one's become an adult.
No, if it's more than 2 years, it doesn't matter. It's still considered developmentally further ahead. That's my understanding. I don't know yet. More than 2 years is always illegal, even if both are under 16. All right. Now there's another little thing there. Yes, so if the disclosure. So now if we're thinking about the sexual relationship that is consensual and not abusive, and one partner is 15 and the other one is 18, and the 15-year-old comes in, and you're happy that there's no abuse going on, and how do you know that? What do you ask? Are you happy? Are you safe? Are you safe? Can you stop the relationship at any time? Do you feel like you're being forced to have sex when you don't want to? Are you being made to do things when you don't want to? Is it a relative? Is it a coach? Whatever. So you're happy there's no abuse, then you don't have to report that as a doctor looking at these people or a counsellor. You don't have to report that. So it does get more complicated because if the partner came in or they came in together, and the 18-year-old is with you, and it's the same relationship that's not abusive, you do have to report that. You have to report the offence, but not the abuse. Does that make sense? Even though, and that's the silly part of this law that doesn't work very well in practice. And I have to say, in practice, what we do is let young people know that this law exists to keep their maturity protected. So they may choose not to tell us the ages. And probably when I'm with the 15-year-old on their own, I'll ask the age because I don't have to worry. I don't have to report that other person because they're not with me. But if I was seeing them together, I might want to inform them about this anomaly so that they have the choice whether to tell me or not. And the other problem is that nurses are not covered by the exemptions. So if you're co-consulting with nurses, it's better the nurses don't ask about the age difference of the partner if they're not worried about abuse. They have to still check abuse. So I would recommend the nurses, if you're doing this checking, that you check that there's no abuse going on, but maybe don't ask the age and leave that for the clinician to decide, because once you find that out, technically you'll need to report that. These are the parts of this law we're trying to get changed, but that's not an easy process.
Okay, just one question. What if the partners are, say, 16, 17, and after 1 year, they're 18, 17?
That's fine, because they're above 16. So up 16 and above, you're allowed to have sex.
Even someone older than 18?
Yes, you are. But if there's a lot of gaps, like at 16, if there's more than 5 years gap, it starts to be in a shade of grey, and you'd be starting to wonder about that. But technically, you are, 16, 18 is fine. 16, 35, maybe you're going to start asking questions. But technically, 16, unless that person's in a position of power, it's probably not an offence. But if it was the coach or the tutor, then probably it would be, or the teacher. Yeah. Yeah.
I'm sorry, I want also to clarify one thing. To assess the maturity of a mind.
Yes, I'll talk about that. Yeah.
Do we need 2 doctors to assess?
No. So only if they're under 14. Sometimes you might, if you're concerned that you're not sure how mature they are. So the things to say about mature minor. So the law recognises that young people, so first of all, the first thing to say is that the legal age of being able to consent to your own treatments or your own anything is 18. However, the law does recognise the consent of someone under at the age of 18 if the clinician is satisfied that that person understands fully what you are proposing, whether it's treatment or not, and the consequences of treatment and non-treatment and all of those, the long-term effects. If you're confident that person understands, then the law will recognise the consent of that person. So that means that you have to do a mature minor assessment for every different treatment. So it's not just one assessment and that's it. It's one assessment for taking the pill. It's one assessment for medication for STI. It's one assessment for management of depression. But there are indicators that can tell you what it is. And it also depends on the gravity of the treatment. So if you are having gender reassignment surgery, obviously it's a very grave treatment with lots of long-term consequences. That's not undertaken until they're 18, even though they can have hormones before that. But whereas a minor thing like a termination of pregnancy is not a minor thing, but it's a straightforward procedure to understand the implications of it and what it means, you could do that much younger. And contraception, if someone gets the fact that they're going to, avoid pregnancy and this kind of thing, they could probably do that at 13 or at 12. And then there's the issue of acting in the best interests as well. But maybe to care for your own depression at 13 is probably not going to be that possible. You're going to need some support and something like that. So it's a very, it's a nuanced judgment. So this was based on Mrs. Gillick. So I won't go through the story, but it has been tested in the case of the prescription around contraception in the High Court, the highest court of the land in England, in the UK, and has been adopted here in the case of Mariam. So as a matter of law. they will recognise the age. And just different states have different cut-offs. So South Australia has 15 or 16, New South Wales has 16, Victoria's got 18. All right, so then Lord Frazier gave a guide around contraception in particular, but it's kind of useful in general. So the professional has to be satisfied the young person understands the advice, the young person cannot be persuaded to talk to their parents. So that just harbours on the good practice point that we want parents to be involved in the wellbeing of their children. So in the discussion with the young person, if they don't want to inform parents, you really want to explore that a little bit. What are the reasons for that? And you have to understand their reasons and accept their reasons, but maybe some of that could be overcome by you offering to have a conversation with them and their parents together. But there's also literature to say, you know, in abortion care, for example, that if a young person says, no, if I tell them they will hurt me, you have to believe that because it's probably true in 60% of cases. So it's about exploring. So if they cannot be persuaded to tell their parents, that's another ingredient. If they're likely to continue having sex, whether you give them that or not, unless the young person receives contraceptive treatment, they're going to suffer in other ways, and it's in their best interests. Okay? And then in general, making a competency assessment, these are the things you have to take into account: the nature and the purpose of treatment, the options, the consequences, the gravity of the treatment, the consequences of not treating. So for the contraception, I'll always say, what if your parents saw that you had implant on in your arm? What would you do then? It's one of the consequences. So we explore that together. So at least they're forewarned about it, and so on. Okay, and then you can understand these things by doing a heads assessment and talking with young people and understanding how mature are they in other aspects of their life, getting a travel ticket or something like that, those sorts of things. Okay, so refusal to treatment's not recognised. Now we're over. Oh, now we're way over. I think I might stop there because I won't go through all the treatments for that. But we're now into the second session. So really just to finish off what you had alluded to us, that after a young person's been talking with you about all these things, you really want to feed back to them. That's great, you come to talk to me. This is what's going well. This isn't what's not going so well. And rehearse what to say if you need to talk to others and welcome them back. All right, so that's all to say. I won't go through that. So, Tamara, what do you want to do now? Because I've got a little bit of presentation on doctors in schools from the philosophy side of it. Do you want me to do that next? And yeah, that's cool. Okay, cool. Is that the other presentation? Yes, and I don't need to do any more cases, but I'll just talk to you about. Is there any other burning? Yeah.
A general question for an age of a child to go into a consultation with a doctor. Yep. Any sort of set legal age they have to be without their parents?
No.
They're under 16.
So it varies with the maturity and the willingness. So some parents say, well, I still go in with my 18-year-old because they don't want to go in on their own and they don't know what to say. That's a sign they're not very well socialised with that thing. So I would be starting to model setting that up to, okay, well, now it's time you come in on your own. Generally around 15, it's a good time to start that separation and bringing it up when they're 12 and 13. Now you're heading into adolescence. If you know them from a kid, they're probably more willing to separate earlier. But some of our adolescent experts we've been training with for years say under 15, they can be quite anxious to separate from parents, and you might not do it the first time round, but you might, after they trust you and know you a bit, you might do it the next time round. So, I mean, it's a rule of thumb that under 15, maybe you don't force the issue.
It's not legal anymore.
It's not illegal.
It used to be 16 and over, but they could be with the GP on their own.
They can be with the GP on their own at any age.
Yeah.
Yes. Yeah. Yeah, even a little one. if I mean a young, like low-end scheme, yeah, that's right. And an indicator of maturity is if they've organised themselves an appointment and actually got themselves there and can go in and talk on their own like this guy did, they can do it.